Hi.
Hi.
Hi. This is better with on my computer. Okay, good. Hi. Oh, look at everybody joining. Oh, there's Carol. Hi, Carol.
Hi, Kendra.
How are you?
I'm good. How are you?
Look at the kitties.
They're there. Can you see them? They're behind me.
Yeah, I love them. My Fox is upstairs. He's not allowed downstairs unless I'm watching him. He's, male cat is he's like peeing everywhere.
Uh-oh. Take him to the vet. He's got a
Yeah,
urinary thing.
I was worried about a urinary tract infection for him, but he seems to be doing okay. I think he's not been neutered yet, so.
Oh.
Yeah.
Yeah, that could be it too.
Yeah, might be it.
Get him brain surgery quick as you can.
Hello, all you lovely people.
Hi, Breena.
Mark just turned his video off. I like your picture, Mark. Looks like looked like you were in a public place.
I like his picture too.
It's so Mark. So I'll give everybody a couple minutes to get on. I'm not sure how many people are actually registered for the live version of this. And just a reminder that you can turn your video off, you can turn your audio off. If you are in a place where there's other background noise, muting yourself while you're not speaking is helpful because that helps the sound recording. And I think I had figured this out before our last talk, but I hadn't been recording all of the views because I didn't know that was an option. So whoever was talking was the view that was being recorded. And so if multiple people are talking or somebody is doing something and somebody else is talking, then you don't see the person who's doing the thing. So I have it set to record all views now. Whatever we get, we have it recorded. And I keep getting this message. Why can't I sign in? Internal meeting only. Please sign in with your company account to join. Have you ever heard that, Kendra?
I've not. So who's it? Is that something that people are getting?
It's Meredith Seeley. She's getting a message that says internal meeting only. Please sign in with your company.
Oh, so she probably has to sign in.
She said, never mind. She figured it out.
Okay, I was gonna say, because I think it just has to sign into Zoom, because it gave me something like that too, and I had to actually because I wasn't actually using my account, I had to make sure that I was signed in.
Oh, okay.
To Zoom, since I wasn't the one that was holding it.
Gotcha. Is that what happened to you, Meredith? Were you not signed in?
Usually I am. So I had to re-sign in, but then it was asking me to input what meeting it was, like as if I was a host or something. It was asking for me like a code. And then I was scrolling through and there was like all these codes of past Zoom meetings I've gone to that have nothing to do with this meeting. And so I have no idea what that was, but I'm here.
It could very well be the way I set it up, because I was like, oh my gosh, I need to get this set up. And I did it on my phone, and you don't have as many options on your phone as you do when you set it up on the computer on the actual website. So I had to go back in. That's why I resent everybody that email, because I was like, nobody's registered. And then who was it? I think Zoe was telling me that she couldn't, she was like, I think I'm in. What do I need to do? Somebody said that. Okay. So I'm just going to go ahead and get started, and yeah, we'll just get started. So Kendra, as I'm pointing to her box, I have nine squares, like we're in Tic Tac Dough, that show, or Hollywood Squares. So Kendra is gonna shed some light for us today on hypermobility. What is that? I was telling her, we did just a little chat previously, and I was saying pretty much, I was like, well, there's hypermobile joints and there's Ehlers-Danlos syndrome. That was the extent of my knowledge. And the extent of my knowledge now is just a very tiny bit broader than that of, it's not just that. There's a whole bunch of other stuff. So Kendra's going to help. And Kendra, I did not open up the questions because I made my smoothie, and I went in and made sure my recording settings were set correctly, and I made my smoothie and came back. So
well, I have my email, so I can try to pull it up too, and you know, I'm sure people ask questions, but also try to look at my phone. This is what I do when I hold webinars for EDS in general. I'm always going back and forth to make sure that I can answer questions. So I have my phone just in case you see it, because that's the way I can.
Okay, perfect.
Things.
And I don't know who asked the questions on the survey because they weren't identified. So I don't know if some of the questions came from people who are here or people who are not able to join live. So
okay, so we'll just try to keep. I like.
If you will introduce yourself and tell everybody kind of your own personal, briefly. So
I am Kendra Neilsen Myles. It's an honor. I don't know if I've ever spoken with anybody personally. I know Carol and Meredith. And I'm just beginning, I'm newer into the RES community. I did finish my certification last year, but prior to that, my history is basically, I was a public health major in college. I became a yoga instructor. Just pretty much been in the medical field since I got out of college and before. I've done medical and pharmaceutical sales. I slowly became more involved in the EDS community and the greater hypermobility community, if you will, after I got diagnosed with EDS at 27. So I've learned and slowly gone through this. I became more and more prevalent in the community in terms of what I was doing. I did a lot of work to help the providers and the patients, but my interest has always been movement. And that's even before being a major in public health. As a kid, I obviously had EDS, or I had hypermobility, and I didn't know what it was, but that's how I dealt with life. I mean, that's just how I learned to cope. I didn't play sports, but I was a dancer, cheerleader, gymnast. But even beyond that, I always felt better moving. And I also learned that while exercise was really important, and I would do my Buns of Steel videos and everything like that, that moving all day long was really important, you know, just to make sure I could go up and down the stairs and carry my laundry. And that if I stopped moving, I always joked that I would just fall asleep. So there's a huge fatigue component. There's all these different things that are part of it, but a lot of the reason why I'm here and why I did the certification and why I've met all of you is because I really came from a very personal background of needing and understanding movement in my life, what I taught my kids, how I've incorporated it, and then the work that I've done in the EDS and broader hypermobility community, and the disconnect that I'm seeing because I'm so heavily involved in the medical clinical side, but my passion, interest, life is in the movement side and in health and wellness and public health. And I found that there's just a big disconnect in terms of knowledge, understanding, but yet because of social media and because of our connections that we're literally and figuratively finding, both in terms of awareness and interest and the clients that we work with, that we're all more connected than we ever used to be. And there's a lot of misinformation. And I loved Katie's podcast where she talked about the horn article on the head. And they were talking about how when research is published, you know, it's published in terms of for your colleagues, right? So it's according with the verbiage that we know or you know. So whether it's public health or whether it's movement and biomechanics or whether it's really medical research or environmental, we all it's written for our colleagues. And then other researchers who've been in the field can read medical research or clinical research or whatever it is because we have more of an understanding of how to do so, but still our interpretation is really kind of biased. And I think that also happens with this. So while somebody who's really into the fascia movement biomechanics side, and they might do some research to understand what's going on here, if they do a query on Google, their interpretation of the one article that they see is really in terms of just their own bias. And so it doesn't really give a full picture of really what's going on the medical side. So this is important because there are politics involved, and does it matter to all of us? I don't know if all the nuances will matter to you all or whether they matter in general because it's constantly evolving and it's frustrating and it's confusing. But I think having a broader understanding of just to dig a little bit further and to really kind of understand that how we might interpret it is maybe just not all the full story, and just kind of having awareness of what is really out there. And and I think that also matters too in terms of terminology that we use. When people might ask you about terminology, the terminology thing is really frustrating for me, I gotta be honest, because it's changed a lot. And in order to help the hypermobility in general move forward, I think making sure that we're using the same terminology as like the medical community and everything is really important. But that also is understanding just the bigger picture of what it, as Breena said, it's not just EDS or hypermobility, just understanding what else is out there. So that's kind of me in a nutshell. I'm very honored to be here. I'll do whatever I can to help shed some light. It might be really confusing and overwhelming. That's what I find a lot, is that once I start talking or people ask questions and I answer, it can be really overwhelming. So, and maybe it's not. And then people, of course, want more information, but I don't want it. Breena and I both talked about how to just try to keep it, you know, as simple as possible, and to then try to maybe create a resource where I can send you guys, where you can know to look for certain things. If you just go on Google, it can be really overwhelming and also frustrating, because it's hard to decipher what's true or not, because not all the verbiage is the same. Not everybody's changed the verbiage and the terminology. So what do you use? Where do you go? What's the most recent stuff? So I'm happy to just try to shed some light on the bigger aspect, and then try to maybe put together something that we can, as RES instructors, can easily access, and you just know can find certain things that are just important maybe for our community and for your clients. So that's it. Do you want to ask questions, Breena? You want me to pull up the questions?
Yes, I'm sorry. I'm trying to get Carla in. She's having trouble and she's getting totally different errors.
So I will, let me just go back to say, let me pull up. So if anybody wants to, I can just start talking if you want me to.
Go for it.
All right. So first thing is that to understand that hypermobility is, you know, people define it different things. It's just the joint that, you know, has a greater range of motion than quote unquote normal, right? You can be hypermobile in your bigger movement joints. You can be hypermobile in your fingers. You can be hypermobile in your tongue. There's a thing where people can touch the tongue to the tip of their nose. It's called the Gorlin sign. I can't do that, but a lot of people in my family can. You can also be hypermobile in your eyes, essentially. Strabismus, amblyopia, things like that I've had since a little kid. If my eye goes in, is essentially a sign of hypermobility in your eyes, because the ligament is lax in the eyes. So there can be hypermobility everywhere. You can be, the cause of it is different for everybody. So I think what's the most important thing to understand, other than you can be hypermobile everywhere, is the reason why that is the case is because your connective tissue is everywhere. And connective tissue, there are different types of connective tissue in the body. I know a lot of us know a lot of the different types of connective tissue. However, hypermobility is usually, if we're talking just completely heritable genetics, is caused by a mutation to the connective tissue. Ehlers-Danlos syndromes, as it's called right now, is a collection of heritable connective tissue associated with collagen mutations, structure and function of collagen. As we all know, there's more things to collagen, to the connective tissue, right? So there's mast cells, there's nerve cells, there's other white blood cells, there's all these different things, and then there's extracellular processes and enzymes that are outside of the cells that are part of the connective tissue. So essentially, hypermobility can be kind of caused by stemming from any kind of mutation to some kind of component in the connective tissue. I mean, I'm generalizing it, but Ehlers-Danlos syndromes is associated with just strictly collagen mutations. But there are elastin, you know, there's mast cells, there's different things like that. And what we're finding is that other connective tissue disorders are not under the EDS umbrella. They're under the greater maybe hypermobility syndromes umbrella, or greater connective tissue disorders umbrella. And they are, the genetic link for them is other mutations in the connective tissue or the processes. But they are also associated with hypermobility. There's Marfan syndrome, Stickler syndrome, osteogenesis imperfecta. I could go on. There's also connective tissue diseases that are inflammatory connective tissue diseases that are also associated with hypermobility. So when I first came on board, if you will, and I first learned, there was this generalization, and then there was EDS. And then, it used to be that all EDS was the same, but it's not. There are different types, and that everything that was not a known genetic marker for EDS was this hypermobile or type 3, what they used to call it, EDS. And so now we're kind of evolved, and the pendulum has swung quite a bit. It's swung back and forth, I don't know how many times, and it can be really confusing and frustrating. So we now know that there's heritable connective tissue disorders that are associated with hypermobility, and their cause is not always the same as EDS. They're more prevalent probably than we currently believe, because at the end of the day, until we're all genetically tested, we really don't know. And that's what's really they're finding even in the EDS research, is that truthfully, it's not only you have a type of EDS if you have EDS, and then everybody else is lumped into this hypermobile category. It's really, we don't know. So if you, so there's connective tissue disorders that are associated with hypermobility, but now we're learning that there is an acquired component. And acquired means something like is triggered on, right? So there's associated with hypermobility with rheumatoid arthritis, lupus, other inflammatory connective tissue diseases. There is a lot of overlap and comorbidity between the connective tissue disorders, EDS, and these too. The reason, we don't know. Why do the people that seem to have a connective tissue disorder have a more likelihood of these other comorbidities and developing these autoimmune inflammatory conditions? Or what part comes first? A lot of times we don't know. Sometimes people don't even know that they have EDS until they have all these other things. And then they go, oh, wait a minute, why am I so lucky to have 100 different diagnoses? Or is it really just one underlying process that kind of predisposes my whole body to these things? I could list probably 20 pathological conditions I've been diagnosed with, but is it really 20, or is it, I do have to deal with them, like my thyroid, but is it, or do I just have an underlying genetic connective tissue disorder? And that's probably the case. So, but there are also things that can make things worse. There are inflammatory processes can make connective tissue more lax. So look at Lyme disease. Lyme disease is also associated with hypermobility. But is it the people that developed the chronic Lyme and the chronic problems and weren't just, they didn't just take an antibiotic and were fine like my dad, or they developed these chronic long-term problems, just more, they had something triggered on that is more indicative of the underlying process of something of how they were born, if that makes sense. Like why do certain people develop the chronic Lyme and have these issues that develop, and they end up looking and being like, oh, it's associated with hypermobility, I'm hypermobile, so is there a process of that chronic inflammatory disease that causes the joints to become more lax? Or is it they already had a predisposition, they were probably a little bit hypermobile, but it made it worse? We know that certain things can make things worse. We know that in the dance and the gymnastics and the yoga community, hypermobility is glorified, right? So, is it that the people are just like that, or is it also the training and how we've kind of learned to think that that was okay, that it makes it worse? And I know that's also where I think that there's a disconnect between like the movement community and fascia and research and what is okay versus not in terms of the movement within the hypermobile range of motion. Not that I'm here to argue that. I don't know. I don't know what the answer is. I just think it can be confusing because what we're all seeing in the scope of our specialty in terms of restorative exercise, movement, and connective tissue and fascia is not necessarily what the providers that speak on my webinars are saying. So they have science and research to back that too. So I don't know what the exact answer is. And like I said, I'm not here to necessarily argue it. I'm just trying to help shed some light in terms of just the bigger scope and what does that possibly mean to us and our clients. I'm not sure. I just think that because we're not going to diagnose and we're not going to solve everybody's problems, but I think that understanding that it's not just hypermobility and you can't just categorize, well, the people that have issues or have conditions, they're really just a small subset. I don't know that we can answer that either. I don't think that's the case. I think the truth is everybody's not been genetically tested. So we really truthfully don't know. And I really believe that there's some kind of mutation or mechanism of action that changes in terms of our epigenetics or our genetics when we're born that kind of predisposes us or causes things to get worse that becomes out. And I think it's going to be really different. And some people might have several mutations that are associated with hypermobility. But I think just understanding that there is a bigger picture, that some people really aren't diagnosed early. There are probably a lot of people that are walking around that have heritable connective tissue disorders. Some of them arguably might be even more severe than other ones, like Marfan syndrome, where there is really important to make sure that they know what they have. I can't determine that, you can't determine that, but just even having resources to refer people to if needed is really important, because these conditions are quote unquote rare, and I think we're finding that, and I know that we're finding they're not so rare. And the truth is we don't really know the statistics of how many people have hypermobile EDS. Truthfully, I wasn't even going to go into this just yet, but hypermobile EDS is probably a number of different things. There probably is something that's heritable in the gene that they'll find, but they haven't found it yet. So it's probably several different things. It's probably epigenetic. It's probably acquired. There's just a lot we don't know. So
I have a question, Kendra. So because there is such a broad, vast range, spectrum, whatever the right terminology is, does it, so for us as movement teachers, how critical is it that, other than understanding that it's a broad range and it can affect a bunch of different body systems and body parts and affect people differently, and it might be acquired, it might be all of these things, like when we're teaching a client who has hypermobility, whatever, fill in the blank, how critical is it that we actually know that, other than having that understanding that it can be a broad thing?
Well, I can say that I think it is important. And obviously understanding that what I was saying is that the connective tissue is everywhere, and there's different types of connective tissue in the body. And obviously depending upon if somebody has a mutation, but that mutation not necessarily affects all types of connective tissue equally, right? But aside from going into the molecular genetics, and the reason why is that if I was working with somebody, why would it be important to just know, other than being an awareness, is that if somebody really if they come in and I'm working with them and they're quite hypermobile, right? And, but they also are kind of telling me, because you get a little bit idea of their medical history. I don't know how further you guys go into what your intake look like or what you ask, but sometimes these things just come out even if you don't ask them. You find out that they've had a lot of prolapse. You find out that they've had chronic issues with flat feet. They have migraines. Maybe they've mentioned that they've had an aneurysm. Somebody in their family died early. I don't know. I'm just trying to think of the different things that are seemingly unrelated, but that are red flags, in my opinion, in terms of how not only, oh, maybe there's something more going on, or hey, this might change how I work with this person. I might not do hanging with somebody that seems to kind of have more tissue fragility, if I say that. Like they might have a lot of scarring on their body. They might mention that they keep getting these, like, like they just keep getting hurt, and like they just get these ginormous bruises, or their skin really doesn't heal, or maybe you just notice that they can have all these visible veins, and their skin just kind of looks really thin. Like mine is very thin and very fragile. Although I'm not as fragile as other people, but my daughter doing gymnastics, she gets rips like all the time on her hands, and the other kids don't. And I just think, gosh, we don't even have, I don't have vascular EDS or something like that, but our skin is more fragile than others. It doesn't stop her, but as much as my life, but I want her to stop hanging, but I mean, she's okay, but there's never been more intense issues. So I think it's just these more of the red flags that if you notice, like, hey, they've got a really extensive medical history, and you're finding out more and more, maybe in the time that you're working with them, that just more things come up. They're not healing as well. They have more pain than usual, like by doing something like a pelvic list, or just something simple maybe that is maybe more on not the harder side, but they're coming back, they're just more fatigued after it. I don't know, these are the red things I think, okay, wait a minute. Not only do I have to kind of maybe modify what I'm doing, but maybe some of those harder things like hanging, I say specifically, I should maybe look into maybe doing a different way. And I say the hanging because if somebody has an underlying vascular connective tissue disorder, and that's not just vascular EDS, that is Loeys-Dietz, Marfan syndrome, and again, you're not going to diagnose, but how prevalent are these really? They're probably a little bit more prevalent than we think until somebody's genetically tested. If their tissues inherently inside just respond differently. It's not just the skin, it's not just their joints, it's internally, their vasculature, the connective tissue that's supporting their joints. And that, even though hanging is awesome, for those people, it's not. Because the risk is so great. So, and that I can't determine that. You guys can't determine that. We're not going to. And of course, we just have to keep moving forward at the end of the day and just work with our clients, right? So is it going to change how somebody does a bridge? No. And how you teach that? No. But it might have changed if I start seeing more red flags of just having underlying really strong inflammatory processes too, that might not even be a connective tissue disorder. It might just be that their body is just really just inflamed and just multi-systemically just kind of not doing well and just reacting to things inappropriately. I might back off, but these are the red flags I look for. They have really severe bruising. I notice their skin looks just really fragile. They might have a lot of scarring. They say they've got migraines, they've had a stroke, maybe they've had an aneurysm. Somebody in their family maybe died early. You notice that when you're working with them, they just get really fatigued or in pain from just simple things, not even a lot. Just you know, res work is not necessarily that intense all the time either. So, you know, if they're just getting really, really fatigued by just simple things, so the bruising, maybe they got eye issues, they've had, you know, maybe they bleed. Like my son has severe nosebleeds. Sometimes things like that, you know, there might be an underlying process like that is a blood disorder too. Blood disorders are also common with connective tissue disorders, which is also something that even if you know that they have that, that might be something also you want to be wary of in terms of how you teach and what you do. Van Willebrand's is what I was talking about. There's another one too, where the people they're more likely to bleed. They have clotting issues. So if they mention that, that might change how you approach teaching. That's just kind of what I do. I mean, that's not, I don't know that there's a checklist, and I don't know there ever would be, but that's how those are the things that change my approach in terms of teaching either yoga or restorative exercise or just movement in general.
So in looking through the questions, I pulled them up. So in looking through the questions, some of them are, I think you've already kind of gone over. There's a whole bunch of different things that fall under that umbrella of hypermobility, whether it's it has a name or it's a hypermobility disorder. It's part of this hypermobility, what did you call it? Spectrum disorder.
That's the new one.
But some of them that are kind of more specific to us teaching, especially in a group setting, and especially considering how many people may not know they have any kind of connective tissue disorder. And like some of the things you're saying, I'm thinking about my daughter. Like I posted on Facebook before about asking about nosebleeds for her, and she has very, like you can see all of her veins.
Yeah.
I wouldn't call her hypermobile because she's got very tight muscles, but maybe she's got more connective tissue.
Well, I will say also that 50%, and I'm going to put my own number out there, 50% of the people that are hypermobile can be super stiff and they're not flexible. So flexibility and hypermobility are not one and the same. So that's also what I say. Not saying that your daughter has anything. I'm just saying that just keep in mind that just because somebody's really stiff and they don't present physically with any hypermobility in the bigger movement joints, that doesn't mean they're not hypermobile when they're under anesthesia. Because if you're hypermobile, you're going to be hypermobile under anesthesia. And I used to work in the operating room, and I can't tell you how many times I'd be like, I used to sell a tissue adhesive, go figure. And I could just see the patients, and I would be working with these physicians, and I'd be like, oh my God, like, wait a minute, like, hold up, like you might need to think a little bit stronger, but I mean, it's just kind of obvious. But so flexibility and hypermobility are different. And that just because somebody's not grossly flexible or overtly hypermobile doesn't necessarily mean that they don't have an underlying process of either a connective tissue disorder, or it doesn't mean that you should ignore it, you know, too. But yeah, so people can be really stiff. And some people with vascular connective tissue disorders aren't grossly hypermobile in their bigger joints. Just, and I know that's similar with Marfan syndrome too. And I'm not saying, again, your daughter has any of that, but I think once you start looking at the things, not everybody that has these things also has a connective tissue disorder. These are just the things that are just red flags. And then also knowing that not all connective tissue disorders or even EDS is people are super hypermobile or flexible, you know, contortionist.
I think that's a really good distinction. I mean, and that's certainly something that we learned in the restorative exercise training, that hypermobility and flexibility are not the same thing.
Yeah.
But that's really interesting, because I would still think that you would see, if somebody had a hypermobility or connective tissue disorder, that you would still see at the joint level somebody who appeared to be more flexible, what is commonly termed more flexible, which we know is a hypermobile joint. But so I'm not unfamiliar with seeing tight muscles but hypermobile joints, but that's a really interesting point that you make. So then it leads me to go, well, what do we do in a group class where you have people who might be hypermobile or have a connective tissue disorder and you don't know and they don't know? What the hell do you do?
Right now, what do you have? I gotta be honest, I don't know exactly if we will ever find out, really truthfully, because it really is independent. But you're right, I mean, men also present very differently. They could be hypermobile, but it's not necessarily, I think it also depends on what we are trained to look at in terms of what's hypermobile or not. You know, when we look at the gross, bigger, you know, the knees and the, you know, the different areas where we can be hypermobile, we're not necessarily, I mean, we kind of can look at the neck, or we're not really looking at the tongue. We're not looking at, you know, there's all these different indicators, in my opinion, that people are hypermobile. You're not going around, okay, can you touch your thumb to your thing? And, you know, we talk about putting your hands to the floor, but like, we're not talking about, okay, let me see all your fingers. And when you're doing that, you know, in case teaching the stretching of the hands, I'm like, well, wait a minute, like, you know, so we're not doing that necessarily in a bigger class. You might identify that, but, you know, what does that mean for us? And, you know, I don't know necessarily in a class, because other than just, you know, you might notice that the person is, you know, struggling, and maybe you can help bolster them a little bit different, or just, you know, sometimes people are hypermobile and they don't even recognize it. You might see it when they're doing this and they're trying to stretch their fingers and their fingers all the way back. But yes, you can have men, even kids too, even though they're more likely to be hypermobile when they're young, like boys, when they get older. Breena worked with my son, Johan. I mean, you never think or you saw me when I was doing my training, my last exit thing. I mean, Johan was with me. He's not necessarily overtly hypermobile at all. But he has other indicators, and his Baton score is actually pretty high. So like I said, you're not necessarily going around and doing, can you touch your thumb to your hand or anything, but I think just being aware of it. I mean, in a class, I mean, what can you do? People sign a waiver and they sign in, and overtly it's our role, our responsibility to take control of our health, right? As an attendee. Right. So in a group setting like that, I don't know. I mean, there's nothing that we really, you got to teach the way you got to teach. I mean, I know that I teach in terms of a group setting the way I teach too. I mean, even though I do an intake,
Actually,
there's just different. Go ahead.
Sorry, actually yesterday I was teaching a group class, and I had a young woman in the class. She looked like she was 17 or 20, like she looked pretty young, and her back, we went into table quadruped, and her back just like bent in half. Like it was, I've never seen it before, like that dramatic. And
yeah.
So for the rest of the class, I sort of stood close to her and did a lot of alignment points with the ribs and the spine and stuff, just to try to make sure that she didn't do anything. Like I was uncomfortable if she did a really deep back bend or something. And then I was teaching yoga. And then after class, I talked to her about it. I was like, you know, are you aware that, you know,
doing this? Yeah.
You can bend your spine really deep. And she let me know, she's talked with doctors, she's talked with physiotherapists, that she's aware of it. But I've had a lot of people with their elbows bending backwards completely. Yeah. I don't know if I'm saying it offensively, bend backwards, but they have, you know, the joint moves very, very deep. And I'll mention it to them, and they have no idea that they have that ability in that joint. So sometimes I'll just kind of let people know, oh, your body does do this. Did you know it? Mm-hmm. And, you know, this is an alignment point that may help them in the future, just to kind of let them know, because so many people have not known. They just have no idea.
No, and I would totally agree with you. And that's kind of the way that I approach it too, because I don't want to ever scare anybody, and I'm not a doctor and I'm not a diagnosis. So just because somebody is hypermobile in one joint, we might notice it, doesn't mean that they have something, right? So that's also the part, is that, and even if they have something, what is it? We don't know. And it's not just, you know, EDS or hypermobility, like we said. So there's so many bigger things that we talked about that obviously are there that, you know, I don't even know, and it's changed since I've been working in this community. But just giving them alignment points for that is really helpful. And also there is truly a really big struggle when you are hypermobile of just understanding your body. Like you grow up like this, and I'm sure people are hypermobile here, and you just kind of learn things, but you don't know that they're different from anybody else. Like the way I moved, I didn't know why I hated sitting so much. I just was ridiculed for it, or why I hated handwriting. I never could take notes in college. Like my hands are a big thing. But I always sat in the front of the classroom and I couldn't sit still, and then I would just miss classes. But like there's all these things that you do in terms of movement, but even movement very on a smaller level, like just taking notes in school, that when you're hypermobile, you just don't really know. It's different, but you don't know that that's not normal, or normal, but is it normal, you know, in the scope of everybody else? You just kind of do it, but you don't know that there's another way that it could make either help it, or that you can learn to be different. So there's a big proprioception thing, issue too, in just terms of understanding how to move our bodies, and that we can move it differently. That might help us maybe not feel so tired, maybe not have so much pain, to maybe make something more comfortable. That's again why I'm here, because so much of the stuff that I learned and I figured out as a kid, just how to deal, is so much in line with everything that we talk about and teach. So that's also why I feel really strongly about it. So I like your point of just little alignment points of the ribs or whatever it is. And I have to say also that I took a yoga class in New York City one time, and there was this girl that I swear to God, I had not seen it then till then, and since then, she literally folded over like a pancake, like that, her back. And I was like, you know, so, you know, is it bad or good? I would argue that's probably not so great to keep doing, even if they don't have issues. But I think just little alignment points privately, maybe just kind of saying, hey, you know, I noticed that your elbows are this way, or your feet are kind of doing this. You know, did you know that your body was doing that? Here's some things to help you out. I think that's a great point, because at the end of the day, we're responsible for our own health and healthcare, and, you know, advocacy, even in a class. But right. Little things that you guys can notice and just kind of help people be more aware of their body will also help their proprioception and what they're learning in class and what you're teaching. Sometimes just awareness that our bodies are moving that way will help us understand what you're talking about and how that applies to us. You know, sometimes I can listen to something or I can learn something, but then to actually see and do it on my body is so challenging. I love mirrors, I love the cameras. Sometimes people can't get it also if they're hypermobile. Like if you give them that point after class, and you kind of notice that they're just more aware of it. They might be more aware of it in the brain, but what that looks like in terms of their body is still hard. So like pictures and cameras and mirrors, like you guys all teach with mirrors too, is really important. That's where I've learned the most about my body too. So.
Other questions?
Can I give some stats for Breena?
Carol just raised her hand. So
I was unmuting. So I have a question about elbow, and this isn't just for Kendra, this is a general question I've been asking everybody, because I started thinking about it primarily because I broke this elbow, and I broke the radial head, which in the end result is that I cannot fully extend this elbow anymore. But it goes straight. Like if you see this arm, this is the broken one, it goes straight. But this one, it hyperextends.
Mm-hmm.
So somebody would look at this one and go, well, that's normal. Mm-hmm. And look at this one and go, that's not normal, or that's, you know, above average extension of the elbow. But what I've noticed that personally is that in any kind of weight bearing activity on both arms, the hypermobile one is the one that can support me. And this one is like trembling and shaking. And I'm like I would never try a handstand now. I'm afraid that this would collapse on me. So then I started thinking, well, what's so wrong about hyperextending the elbow? So then I looked into some research, and I found out that the only thing that can happen if you're extending your elbow, is if the olecranon fractures, right? Because if you look at the elbow, the olecranon fits into this little groove, and it's only going to go as far as it goes. And then the only thing that could make it go further is if it fractures, which is pretty rare. So it's not a thing where necessarily where your ligaments are the restraining, like it's an actual bony end range, and it wouldn't put more stress on your ligaments, I would think, if you had that deep fossa. So, and I understand that women have that deep fossa more than men, which is why women hyperextend their elbows more than men do. So it's like, unlike the knee, which, you know, there is no bony end range, like virtually you could just kind of fall off your knees at some point. So what do you think about that? Like, do you think that there's something really inherently wrong with hyperextending the elbow?
My gut is, I'll tell you guys two things. One is that there's research, just we're going to make it general, and there's some writing, and I find fascinating that the reason why hypermobility, for whatever the cause is, has sustained and is quite prevalent actually, and I'll give you guys the most recent statistics and just in general, is that back in the day when people were hunting and gathering, that having ability to be more limber, bendy, flexible, hypermobile maybe, to run from animals or when you're hunting, to get under things, plus having more laxity in the vasculature, pump more blood. So is it that it's not so bad, right? And maybe some inherently actually beneficial to us. It's not so beneficial in our current society and the way that we live and our movement patterns, right? That's where on a research scale that I'm fascinated. I think that there's a lot to say kind of what Carl said in terms of, you know, is it bad? You know, is it being hypermobile bad? Maybe you're talking specifically in the elbows. And I don't know that it is or is not, because I think there's some argument that there is a benefit in terms of what I just said. But in our current society and culture, in the way we live on average, and without talking about specific mutations, that it's not. Right? So I think it depends on each individual, but I would also say—
I'm talking really specifically about this joint, because it's the one joint that actually has a bony end range of motion that is potentially considered visually hyperextended.
Right.
But it's at its end bone range of motion. It will not go any further than that. There's no way that the ligaments could be loaded any more than that unless you fractured.
Yeah.
So I guess unless somebody has really brittle bones, you know,
and that's the other thing I was going to say, is that a lot of connective, you know, again, not going into every single mutation, is that the other thing I would say is that inherently, you know, do we know that hypermobility is bad or not bad? I think there's some arguments that it's good, but also that the different connective tissue disorders, they affect the different connective tissues. And biomechanically, what does that mean when you're looking at the skeleton of people that have different mutations? It might be arguably different in terms of what kind of mutation they have. And how that affects, and some of it does affect the bones. And, you know, I don't know that they would actually stack up the same way, and it would be exactly the same. But I think you're right. I think you make a good point. I know there's been more research and people discussing lately in terms of moving within a hypermobile range of motion, whether or not we should be telling them to keep within a quote unquote a normal range of motion, you know, and that's—
well, you know, Katie was always like, don't hyperextend your elbows.
Right. And that's what the providers that I work with, that's what we say, and that's what we cue. And
yeah, well, that's what I cued too, until I realized, like, oh, I've bent this one and now I can't stabilize on it.
But it also could be how you have learned proprioceptively to move within your lifetime too. So is that specific to just you and how you've learned and your neurological connection for you? Yeah. And would that transfer to somebody else? And I don't know if we exactly know that, but I think it makes a good point to discuss.
Well, I broke this two years ago. So what does everyone else think? I mean, in terms of, you know, what we've been told to like bend the elbows a little bit and stuff like that. Do you find that is a—
I'm curious
asking?
Yeah, I think it's a really interesting point that somewhere on one of the groups, somebody posted something about some video where somebody was talking about training into that hypermobile range of motion. And I don't know the answer, but I think that's a really interesting question of, well, if if you have this, if this is your normal range of motion and you stop here, like if here's normal, quote unquote, and yours goes to here, but you only ever train to here and you miss this, are you actually missing part of your normal range of motion? Is that kind of what you're asking?
No,
like is that kind of part of the question?
But I know that argument too, and that argument, you know, usually comes up in the controlled articular rotations in the FRC business, because they want people to, you know, to train strength in all kind of potential variables. So you know, if your knee falls in and you never train with your knee fall in, and you're always taught, you know, track your knee perfectly straight forward, then when your knee falls in, you won't know what to do. But that's different, because I'm talking specifically elbow, because the elbow is the one joint that actually has a bony end range of motion that will lock it into place when it's hyperextended,
Right.
or when it's just extended, whatever your range is. That's the end. It's like the olecranon fits into this little groove, and then it goes that far. I don't know if you can see that, but if it went any further, the only way it would go further is if that head broke off. And that's not likely to happen if you're just on your hands and knees.
So Carol,
Yes.
when you say that your hypermobile elbow is the one that can stabilize you, is it in its hypermobile range that it stabilizes you?
Yeah.
What happens if you bring it back to a vertical rather than it being?
Well, it depends on the load. If I'm just doing a quadruped, it's like I can put that elbow anywhere and feel good. But if I start putting weight on it, there's no way I'm going to go up in a handstand without hyperextending it.
Right.
And now that this one can't do that, it's like this was the one that, well, for one thing, it's shorter. That arm is shorter.
Yeah.
Because the elbow doesn't.
So you're stronger in your hypermobile range, and now that this one is being pulled back and it can't go into that, now it's not as strong.
Yeah, it cannot access the full bony end range of motion.
Right.
I don't know what's stopping it. Probably some ligament that's in contracture or something.
Yeah.
I mean, this is pretty common when people break the radial head, they don't get full range of motion back.
Right. But what I'm wondering is that because through the course of your life and loading in your hypermobile end range or beyond vertical when you're in quadruped, if maybe now this one isn't allowed to, if maybe that. No, because for years I did what Katie said, which was to bend the elbow until they were actually straight. Were they both like shaky then? Would they both be like shaky then, or?
No, they'd be strong. So I could strengthen it anytime. So now it's like, anyways, it's not a personal thing that I'm asking. It's just like, what's so wrong about it hyperextending the elbow if you're in bone, as opposed to hyperextending knees, which is actually when the femoral condyles are compressing the meniscus in the anterior knee.
Right.
So you're compressing the front of the knee. If you're going backwards in the knee, you're essentially doing this, right? Whereas with the elbow, you're locking.
Right, but then you're locking on the back of it, but on the front of it, I think it would depend on the ability of the length of that person's biceps, maybe, and the bicep tendons to be able to bear that, where that could eventually maybe lead to damage if you've got short, tight biceps and you're always blowing through and pushing into the connective tissue to get into that hypermobile or full extension range. That would be, that might be something.
Because I just think that if you have this, I don't know, let's call it an anthropomorphic dimension. It's like you've got an elbow that goes beyond vertical when you're straightening your arm, which means that your olecranon sits deeper into the olecranon fossa or whatever it's called, I'm not sure. And then, so you're going to be growing up with that. Like that's the way you are. So I'm assuming that your muscles and your ligaments on the interior side would match your range of motion in your bones. Just the way if you have joint ranges in any other joint, the tissues develop to, allow it or not. But it's like, if you don't use it, maybe not, but if you're using it, for sure, they'd have it.
Yeah.
I don't know, like I remember I remember reading in that book, The Science of Flexibility. It's like a metadata book where they collected all this research from all over. And I remember reading specifically in that book that it said that if you have a tendency to hyperextend things, you may have pain later in life. That's the reason why a lot of movement teachers are trying to get people not to do the hyperextended things, is that it might lead to a pain in the elbow eventually, or maybe in the shoulder because the elbow is doing something and it's affecting the shoulder.
Yeah, I was told that this one would probably now, I could expect it to have arthritis at some point and maybe need the radial head replaced. Like, this one's fine. So anyways, I'm sorry if I derailed the conversation there. It's just something I've been thinking about lately, and it kind of was a hypermobile.
I think it's a great question because it's more indicative of like what we're doing and how we teach people. But I also think it really brings to the table exactly kind of this broader aspect that I was saying, is that even though you might not need to know everything about every single hypermobile associated condition, disorder, whatever, but that there is so much we really truly don't even know yet, also in terms of movement on a cellular level, biomechanically, because these differences do make a difference in terms of the biomechanics of how a person's body is built, the building blocks of a person's body. It also affects their neurological and their autonomic nervous system and how we process senses and information from the world. A lot of times people with connective tissue disorders are also, like I mentioned, the proprioception, but the way we sense the world and the way that it goes through our body, because it goes through our connective tissues and our cells talk to each other through cell-to-cell transmission, and is different. And it's not always the same. We can be hyper or hyposensitive. And there's a huge neurological component to a lot of these, hypermobility related conditions, and how we learn to move our joints, or how we're even training to get better. I say that with quotes because I don't know really what is better, and it seems to be very individualized, because everybody also, even if they have the same condition or the same molecular process or mutation that caused a certain box of conditions or condition, and you fit into the box and you're diagnosed that way, if you are diagnosed, that as you go through life, we have different things that affect us and to affect our presentation, and we might have something else. So I think there's a lot that we don't quite fully understand yet, not just medically, but also biomechanically, because we don't do research that way. We don't look on a cellular level and say, well, wait a minute, how does this type of mutation affect the body? Because we have to speak general, we have to learn generally. But I think we're finding is that really isn't necessarily a smaller case. I think there was a stat, I was going to give you guys a couple stats that were more associated with hypermobility in general that I think are important to be aware of, but there was a great statistic and study that came out that talked about like looking at the genetic mutations that babies were born with, like just as a thing. And it said that, you think that the majority of the population are born with no genetic mutations. And this is not necessarily associated solely with connective tissue disorders. This is just in general, that, babies are born with not a lot, that it would be the minority of like issues, like genetic mutations. And they found that a lot of babies are born with a genetic mutation, whether or not it's going to become a problem or not in their lifetime was kind of undetermined, but they were saying that they really weren't expecting that. I don't know, I'll have to look at for the study, but I thought it was fascinating because I think it really just proves that so much of the stuff that we think is rare, or we're told is rare, or is currently known as rare, is maybe not that rare. And that changes a lot of information, whatever the specialty is that we're in. And I just think that there's a lot in our lifestyle and our culture and our society that changes the presentation of our genetics on a cellular level too. And that also leads to movement issues. So I don't know, I think Carol makes a great point, and I wish I had all the answers, but I think it also depends on, I always go back to what's really going on what their underlying connective tissue disorder is that's causing that. But I think she's just talking specifically biomechanically. But I will say, unless somebody has another question, I was going to say there's a couple of studies that have just recently come out that I think are really, really interesting. One was specific to the genetic variants in connective tissue disorders associated with connective tissue disorder were associated genes. So basically the genetic variants in connective tissue disorders were were prevalent in the professional dance population. I've shared this, some people might have seen it if they are friends or with me. It's 88% in this study. So the prevalence of genetic connective tissue disorders, not just EDS, but just connective tissue disorders associated with hypermobility, because I think a lot of connective tissue disorders are mostly associated with hypermobility, was 88%. So it said that the prevalence in each variant of the different types of variant mutations was never reported. It ranged. So it says the prevalence of each variant ranges from never reported to 0.33% to 33% in the general population. In the study population, the prevalence of each variant was 3.31%, 3.13%. So what they looked at is just this subset of dancers, right? Professional dancers. And they found that 88% of those that are in the professional dance population had some type of connective tissue mutation. And that the prevalence of the mutations that they were looking at was 3.13% essentially for each one. So very varied in terms of the mutation found, but a high percentage had some type of connective tissue mutation. I thought that was fascinating. I don't think it's very surprising for many of us, but I think if you look at that and look at like the yoga community or the gymnastic community, or even, you know, look at swimming and what's his name, Phelps, he's got some kind of something, you know, they've talked about it, they've never released what he has, but he's very hypermobile. So is that, I mean, it's seen as an asset. I mean, look at Lance Armstrong too. I believe that there's been some talk too that I've read that he has some kind of underlying something because his heart has more laxity in terms of pumping blood. I think it's an asset for Olympic athletes personally, but we're not going to go there. But I think it's very interesting in terms of the biomechanics and how people move their body, and to say that it's bad or not bad, I don't know. Unless somebody else has another specific question, there's a
Does anybody else have any questions that we haven't touched on? Okay, go Kendra.
Okay, so there was recently, is somebody talking?
No.
Okay, there was recently a study that was looking at just, okay, well, how many people are really hypermobile, right? And what is the prevalence of like hypermobile EDS? Now, mind you, the way that we categorize hypermobile EDS has changed in the last almost 3 years. So the way that people were diagnosed in their category was different. But it basically, the study, and I can share this too, it's very confusing, but it basically, they did a cohort case-controlled study, a case-controlled comparison in the UK, where they looked at the diagnostic prevalence of Ehlers-Danlos syndrome, and they put hypermobility spectrum disorder. Now I say Ehlers-Danlos syndrome because I believe they just said Ehlers-Danlos syndrome versus syndromes, because I think that they were just looking at hypermobile EDS. And they're trying to use current terminology versus previous terminology, and that makes it even more confusing. But it was found that it's obviously not quite so rare, obviously, and that it is quite prevalent. So the current stats that a lot of times people find online of just maybe statistics of EDS is changing. It's not necessarily current, and it's, we don't know a whole lot, but that it's quite more prevalent. So this is, I'm just looking at the statistics. They looked at 6,021 individuals. Men were about 30% of the population, women were 70%. They had a diagnostic code, this is previous, diagnostic code of either EDS or what the old one was JHS, Joint Hypermobility Syndrome, which is a terminology we don't use anymore. They had a diagnostic imprint of, let's see, they had roughly, it's hard because they did this. So let's see if I can just give you a stat. The conclusions was basically that EDS and JHS, which are now since March 2017 classified as EDS and HSD, have historically been considered rare diseases only affecting the musculoskeletal system and soft tissues. These data demonstrate that these assertions should be reconsidered. So and the statistics are there, it's just, they're quite more prevalent than we thought, but there's obviously a lot that's happening in the medical and clinical research to kind of understand really what's going on. But I think what they're finding is they're opening a Pandora's box of we don't know. We know a little bit more, but we're getting there, but it just brings up all these things that are so much more complex than we really understand. So what does that mean in terms of, you know, who you're working with? Well, one, hypermobility is obviously not that rare, and it's quite prevalent in the population in general. What causes that is probably really varied. And to assume that it's benign is probably naive. And that over time, over a person's lifetime, it can become severe. And there's other factors that go into that. You can't diagnose everybody. You can't even tell them to go get diagnosed. And but just being aware of the bigger picture and to help them learn how to just move within safer range of motions or more comfortable range of motions if they are uncomfortable or maybe they're not even aware of, I think is a great point to start. But just having awareness of the bigger picture. And of course, if you want to delve into the statistics with me and the molecular basis and what it looks like on a cellular level, I'm happy to go into that, but it can be quite overwhelming, especially when I bring up the topic of mast cell issues. So I'm happy to answer more questions, but just the other thing I mentioned, the mast cells. So the mast cells, and this for me just intuitively helps understand the process biologically of like inflammation and pain and different things that people experience that are musculoskeletal and also on the tissue level. The mast cells are our first line invaders of our entire immune system. They are our guards of our body, the sentinels. Their mechanism of action is to basically be triggered by a toxin or something that our body doesn't like, and they release 400 plus different chemicals, including histamine and tryptase and different things. And then they start the chain reaction of our entire immune system. However, they also are a type of white blood cell, obviously, but they are only in our connective tissues. So in all connective tissues in our body, all types, the most prevalent components, building blocks, are collagen and mast cells. So you can look at the different types of connective tissue everywhere and where they are more prevalent. And there's certain types that are more prevalent in different parts of our body. The type that's in our skin is necessarily different than the one that's wrapping our organs. But collagen, then there's like 12 different types of collagen too. So but collagen and mast cells are prevalent, the most prevalent in every single one of them. So, and every single type. So basically we have these immune cells that are only in our connective tissues. They're everywhere. They're in our skin. They cause hives. They can also cause food allergies in our stomach, but they can also cause systemically a lot of issues. And they can also lead to multisystemic manifestations of issues with movement. So that's where I think, just kind of understanding the connection between the biomechanics and the immune system they're really quite connected because, basically our immune system, our connective tissue helps modulate our immune system. So.
Wow.
Yep.
That's fascinating.
It is. It's actually quite fascinating. I think it makes a lot of things really make sense, whether or not you understand the mutation that makes somebody hypermobile. But if all those chemicals essentially are constantly being released into the tissues, and some of them are heparin, other ones are basically like meat tenderizers. Well, basically over time, if they're constantly being overly reactive inappropriately, the mast cells I'm talking about, they're constantly just overly reacting. That's where we get a lot of swelling, tissue edema. But over time, what do you think that can do to the tissues? That can actually make them more lax. So, that's also a big component too, is that if you notice that people that have a lot of biological inflammatory processes, they're also more hypermobile. Maybe they didn't know that they were even hypermobile before. I think it's fascinating because my aunt has psoriatic arthritis, and she also has a lot of other issues. She clearly has, some type of connective tissue disorder, probably arguably whatever is our family type of EDS, but she was never diagnosed. And I think it's funny because now that she cannot control her legs, like she has a compression in her spine and she's too severe and too down and out, she can't walk. But now her knees are just constantly going hypermobile. Like when she walks, it's like a process, like it just does this thing. And she has to use a cane and a walker, and she's even had people at doctor's office being like, wait a minute, look at your leg. And it was so fascinating to me because her knees never did that. And to see the process, not that she just can go there into that hyperextended range of motion, but that it's doing it in her movement pattern now was absolutely fascinating for me, of course. And I wanted to take a video to show you guys because she was never like that. And to me, that was just really indicative of this inflammatory process in her body. And the fact that she was losing nerve control and like more, it was just shows what was happening in terms of her connective tissue structure and function elsewhere of her body over time. So, you know, that's a whole rabbit hole that we can go down, but I think that's really, that can happen. So, and that's why connective tissue diseases, which are rheumatoid arthritis, psoriatic arthritis, lupus, are also associated with hypermobility. Now, is it that they have some kind of underlying process, you know, heritable connective tissue disorder or something before that kind of made them more predisposed to these conditions? And then once this inflammatory process started in their body, it made it worse and more obvious. I don't know. That happens a lot though.
Interesting. Julie, did you have something? I saw you took yourself off mute.
Yeah, I sent a chat question actually, and the question was
I see
just,
it.
yeah.
Is there a movement strategy or something you've learned that has made a difference to you in your overall health and movement that you could share with us? Are there principles that you think are critical for us to understand?
Well, one, I think the idea of natural movement and restorative exercise is paramount. I really do. And I know that there are other people, like I work with this guy, I don't know if anybody's ever just happened to notice him. There's a guy named Adam Foster in the UK. He's called the Fibro guy. He's one of those people that's, you know, he deals a lot with hypermobile patients. He kind of came out with fibromyalgia as another one that's so common and is linked. There's other comorbidities that are very common with people with hypermobility. For example, I don't know if anybody's ever heard of POTS, post-orthostatic tachycardia syndrome. Sometimes that happens a lot with teenagers. I don't want to go down the rabbit hole of all the different conditions, but sometimes those are also, like if people have been diagnosed with certain things, I kind of notice those are red flags for me. But I think just helping people learn, you know, just how to move naturally, even like what they're doing when they're brushing their teeth or how to go up the stairs, has been probably the most important thing for me personally, and also just moving. I mean, I have to do junk exercise and I like doing junk exercise, but I also, you know, I have my other issues because junk exercise doesn't necessarily equate to me moving better all day long and not having pain when I'm cleaning my house. When I'm cleaning my house, and this is a question I was going to ask somebody one day, because every time I clean my house, or I do, and I'm up on my feet all day long, I get this annoying, like I feel like I have a stab in my back, and it's almost like there's something that just moves out of place, and then it compresses a nerve in my ribs or something. So I think the idea of restorative exercise in terms of what we teach and how we approach it is probably, and just an understanding to help clients understand why that's important, has probably been the most important thing for me, honestly. I don't know if that exactly answers the question, because there's not really one role. It's just more of just helping understand my body, and, you know, me doing things that are, you know, with my family or my kids, or this pain I keep getting. It also makes me incredibly fatigued. The fatigue is a really big issue, and learning how to like position my body and move all day long better helps with the fatigue too. So it's not perfect. It's not going to be an end result, but I mean, it's because there is still stuff that's just there. And, you know, the idea is that if you're hypermobile, your body is working overtime to support you as you go through your life, right? Because it just has this bigger range of motion and it feels the world differently. And so it's just this, you know, it's just more fatiguing, you know, structurally, that we can't even really quantify. And it's hard to explain. So just understanding how to go through life and just position ourselves, and just like doing the dishes or brushing our teeth has been really important for me, or as a strategy, I guess, that has been the most critical. And going up and down the stairs, like I said, or
so for you in your daily movements, are you utilizing those alignment points to help kind of modulate where you are and stay within what feels like a safer range for you?
Absolutely. Yeah. And I'll tell you, it's every day is I do it every day. I mean, I would say all day long, especially if I have pain, like I'll try to just, try to figure out what I'm doing. Like I told you, I have this back thing that I would love to just talk about. I was like, I need to show people because I don't know what I'm doing. And as I told you, it's a big proprioception thing. There might be a strategy like I mentioned, but to understand what that means for me, I think I'm doing it, but maybe I'm not. I don't know, just seeing it is different. So yeah, I would say I mean, calf stretching, like all that stuff, I do that all day long. I mean, and it doesn't make it perfect, but that's my strategy, is just understanding that, I guess if this was a strategy, this would be it. It's not just being aware of my alignment and how I move in an exercise class or PT or when I'm working with an instructor. It's also being really aware of it and thinking about it while I'm moving all day long. That's been a bigger, I guess, strategy and a mindset that I don't think that a lot of people do. And I don't think
that's why we exist.
Yeah,
because
exactly.
Nobody does that.
So that's been a really big thing for the hypermobile community. They're so tired. They're really, I call it the EDS spiral. Their body's super deconditioned. Even just getting to a PT or to an exercise class is a big thing. And that's why I developed this thing years ago called Just 5 Minutes. Because everybody be like, what, how you're stronger than us. You can do things more and blah, blah, blah. And I'm like, I'm not, I'm really, this is just how I approach my day. I just move for just 5 minutes just to get my body moving and being aware of it. Like, even if I'm just cleaning or if I want to spend time with my kids, it's not just thinking about movement and how I'm moving in an exercise class or a PT, because sometimes people are so deconditioned they can't even get there. But just starting with what you can do, even if you're laying in bed, is important. Like, a lot of times they're laying in bed and then they come to you guys or they come to us and, like, I don't know, I think that's just, they don't even know how to move and get out of bed safely. So how are they gonna go to a class? So that's my strategy, is exactly what we all do. And that's why I'm here. It's why I exist. It's why I truly believe in this. It's why I want to hopefully do research and study in terms of, so yeah, my overall health, walking, movement. I mean, I love going outside. All the research about just walking and walking more is so important. Doesn't necessarily.
So do you find in paying attention to your alignment and your everyday activities, like everything else, do you find for yourself that becomes more habitual, where you're like, oh, just like if this was my posture before and now this is my new posture, this is my habitual posture of keeping my ribs in a more neutral position, so my back doesn't hurt anymore and my back doesn't get tight like it used to. Do you find the same thing, or is it still, because your body just goes wherever it goes, is it still like a constant thing? So then that must be brain fatiguing as well.
I would say it's both. Definitely the points make a huge difference. I will say I went to Disney World in July and I wore my Vibram shoes and I was walking all day long, all day outside, of course, and I didn't have the back pain that I was talking about. So yeah, on a daily basis, I mean, instead of just going like this, I can do a thoracic stretch or I do a calf stretch, and I can do these different things that I'm constantly aware of. And it does make a difference in terms of my endurance and not getting these pains. But it doesn't take it away fully, but that I have more tools in my toolbox to know how to help myself versus saying, well, I'll just wait until I go do that exercise class. I think that's also, it's a mentality thing that has been a really big, important shift for me. And I think that's why I also try to tell the community too, that to not necessarily think about movement and the strategy of how to like live well or restore your function. I always say restore function and live well in terms of just in this box of this class or this scheduled time. So think about it in little bits all day long and what you can do. So having those tools in my toolbox when I do have that pain has been a big shift. Not to mention it does help that habitually over time, I'm not hyperextending my legs. I'm, keeping my ribs down. I know how to, if I am in a class or something, I know how to like have more proprioception and awareness of what my body is doing than I ever used to. So, but that also transfers to like, how am I sitting at when I'm brushing my teeth? And this is a big one because I didn't even think about this until I was doing it. But like, if okay, so I know how to I'm in a class and I know how to position myself and I think about my knees and, relaxing my quads and keeping my kneecaps down. I'm not hyperextending. You can't see my thing. But if I'm brushing my teeth, I was going like this. Or I was like leaning on the counter like this. And so just being aware of transferring what we learn into our daily movements has been a huge thing for me. And I think it's huge for everybody, hypermobile or not, to be honest with you. But just being aware of those positioning and pain, because I think a lot of pain also comes from like, you know, what we do daily. So there's a habitual stuff of just being aware of it has been, from a strategy perspective, has been kind of.
So there's a part of one of the questions on here that that I don't think you've really talked about. It says, what is happening in terms of outcome of surgical interventions that occur prior to diagnosis with hypermobility syndromes, and are they causing further complications and harm?
That question is an excellent question. And I have to tell you, in terms of my frustration of like what is happening on the medical side, that is my biggest one. I'm probably a broken record and probably I try to not stick my opinion out really too much in terms of that, because the providers that are helping us and then the surgeons, you know, they're trying the best they can and, you know, arguably are trying to do things the right way and for the right reasons. But I don't have those stats. I gotta be honest, and they're not there, and I don't understand why. It's very frustrating for me because I feel like it's this underlying thing that's happening, and it's been more and more surgeries, and they have a next, somebody has a, you know, they have to have surgery for Chiari malformation or instability of the neck, but then what happens, they end up having more and more surgeries. That's not always the case, but, and the surgery, if you're just looking at it specifically, this one surgery, the outcome could be good because it's stabilizing that area and the issue that the person was going for. But a lot of times what happens when they stabilize and they fuse, you know, or do something for one area, well, then it tends to trigger connective tissue issues and more issues of instability elsewhere. Because now the body can't move the way that it was supposed to and learn to over time, being in this range of motion, and also doesn't move arguably biomechanically the way it's supposed to. So those statistics aren't there in terms of the surgeries and what's happening. I feel like I see more complications and issues over time that are happening between the people that I watch. That's a really, really hard area for me because I don't want to, the statistics that are being asked, I don't have them. I've seen certain ones.
The surgical interventions, are they primarily fusions? Is that primarily what?
No, I mean, it could all, like, I mean, that just happens to be like kind of a hot topic, but it could be like Chiari malformation, instability of the neck, but a lot of times the fusions of one part of the spine will lead to more.
Right, well, we know that, and so you know, we know that just in humans, but so I'm thinking, oh my gosh, so if you've got somebody who's got hypermobile connective tissue, and then you do that, you're creating an even bigger.
Right, so then sometimes all of a sudden, you know, they do one shoulder surgery, then all of a sudden if they need to do the other shoulder, or like, you know, it does transfer to more than just fusion of the spine. Right. And I say it does. I've seen it. There's statistics to show for it and what the success rate is. I mean, a lot of times the success rates that they're looking at in surgery are just specifically for that surgery. Right. And that's what's hard. But I will tell you that this is where I also have a hard time, because not only do we really statistically know what's happening with these surgeries, and of course it's always biased in terms of what they're looking for and what they're including, but like somebody with vascular EDS is supposed to not have any type of surgery because of the fragility of the tissues of the vasculature. So arguably, surgery is an absolute last resort. So if we're talking about really a deconditioned body where, like, you know, they have underlying mutation, plus they have all these inflammatory issues, you know, they go into surgery, I mean, the body it just deconditions the body even more. It causes more inflammatory issues, you know, and it seems to transfer in terms of just the connective tissue laxity presentation.
Yeah, go Chris.
I was asking in terms of, like, you know, you have lax connective tissue, you're going to see more prolapse, maybe in a undiagnosed situation or an early stage situation where you have a large uterine prolapse and the surgery that's recommended is a hysterectomy, and now you're lacking this organ that other organs were relying upon to, you know, to hold in, you know, in place, so that more things begin to shift and move. And, you know,
I agree. I can tell you that's why I haven't had a hysterectomy, and I probably should have years ago. But when I asked that question, you know, in terms of the providers that I work with, and like in theory, what do you think? And then I also look for research. There is nothing there. But I can tell you, in my mind, that's exactly why I haven't had a hysterectomy yet. I mean, I'm supposed to have one, but like I've had pelvic issues my entire life, and that's what I was told. But it's not there. We don't know yet. And then I would also, you didn't even mention, like the whole mesh thing is also a thing. And a lot of times people with hypermobility related conditions or disorders or whatever tend to have more issues and reactions with things that maybe other people don't. But then you argue, well, anybody that's had the surgery might have some kind of something, I don't know, there's other different issues that cause these things. But the statistics, we don't know yet. I mean, there's no research to really say. I know that I've had a number of people that I work with and friends in the community that are hypermobile that have had their uterus taken out, and they feel a 10 better and they feel great and they've done just fine. So I think that's also where restorative exercise is so important, and really supporting the pelvic floor and learning that, because how much do we know is not just attributed to the fact that our society or culture, shoes, everything just really is just making the pelvic floor just totally unstable in a way, biomechanically and naturally it's not supposed to be. So I don't know the statistics. I don't know that it's there. I can tell you that's why I haven't had a hysterectomy, because that's my fear, but I haven't had any prolapse yet either. So,
Why have you been recommended to have a hysterectomy?
Because I have, before I was even diagnosed with EDS, I was diagnosed with a condition called interstitial cystitis, which is painful bladder syndrome, which is related to mast cell issues. And I was also diagnosed with pelvic congestion syndrome, which is basically varicose veins on the uterus. And I had that before I ever had kids. So sometimes that's associated with like more vasculature, more blood going to the uterus. Well, I had it prior, and I used to have so much pain. I couldn't even walk. And the more that I was up and walking, the more it was painful. And that was really hard for me, because my answer to everything has always been movement. So this was one thing that, like, literally, I mean, and I'm not TMI, but I'll open book. I mean, it affects your relationship personally with your husband greatly. I just got married and we were together. I mean, it was like, I would have to be in bed for at least 6 hours taking ibuprofen. It was the only thing that I could not deal with movement. And I didn't know how to deal with it. It was like, I don't know what to do. So it's basically varicose veins on the uterus. And I didn't do anything about it until after I had all 3 kids, because I didn't want anybody touching my uterus. But I had a lot of other issues too. I have ovarian cysts. I have irregular periods. I have, I've had irregular hard periods my whole life. I found out that I was supposed to be I was on birth control. I used to sell birth control, and then found out I couldn't take it. But so by the time the pelvic guy told me, like, before I had kids, like, you're going to end up having to have a hysterectomy. And so I just didn't want to do anything about it. Even just what they take that vein, that's varicose vein, and they ligate it, they tie it off so the blood doesn't go there. I just didn't want anybody to either try that, touch my uterus, or even take it out until after I was done having kids. I did do the vein thing. I had my right ovary taken out. They took out my appendix, because I guess that's also associated with pelvic issues, inflammatory issues, as the first line to try. But I was also scared about, like, well, if you're going to take out everything, because you can't just take out my uterus, they're going to have to take out my ovaries that are producing the hormones that I tend to have issues with. I was kind of allergic to hormones. It just made everything inflamed. Well, what's going to be there to support anything? So, that's why I have fibroids. I found out I have fibroids. I just had a ton of pelvic issues my whole life. And the only way to really solve it in terms of the current medical understanding was to just take it out. So I've just been trying to avoid that and try to go other ways, and trying to learn, more about what's a part of it. I don't, part of it I just still suffer through, but the little things that I've done do help. But that's why, it's because I had a lot of, they also think I have adenomyosis, which is not endometriosis, it's a sister to it. So it's like the tissue, the endometrial tissue, when you're shedding the lining, instead of going outside of the uterine cavity, it kind of builds inside the tissue wall, and it makes it thickened, and it raises your risk for cancer. So that's why there's a bunch of different ways, because I have a laundry list of issues.
Right.
Yeah.
Was that question from you, Chris?
That question was from me.
Okay.
Yeah. So I wish I could tell you the answers, but we don't have any of that. I think your thought is correct, and I agree.
Okay. How can we talk a little bit more about the vascular EDS and
Sure.
surgeries? So what are some of the symptoms? Like I have a friend with EDS, excuse me, who almost died from bleeds in her stomach, where, you know, they said, oh, you have ulcers. And she's like, I don't have ulcers.
Right.
Just these, you know, I don't know if it was veins or if it was arterioles or what, but they basically just ruptured and she bled into her stomach one day. And, you know, she coded and everything. And it's, of course, it's a huge, you know, she's fine now and it's been a few years, but it's you know, scary. And she is always seeing bleeds in her skin that happen spontaneously. And
Under the skin?
Yeah.
Yeah, she's not bleeding out. It's like
it's called
like,
probably small vein ruptures. It's small, like small vein ruptures.
Yes.
Yeah.
Yeah. All the time. And of course, you know, she is an outdoors person. She loves to walk and you know, explore the world and nature and everything. So she's in good physical condition otherwise. But to her, it's like a huge issue. And she's seeing medical professionals and they're like, wow, you're so healthy. But, you know, at the same point,
right.
You're so healthy. This is so great. You're wonderful. But, you know, she's like, yeah, I'm bleeding here. I'm bleeding there.
Yeah.
I think urinating blood is like a constant.
Are you kidding me?
No.
Oh, okay. Well, I tell you, you have absolutely invalid reason to be concerned for her. And I would be too. And she has every valid reason to be more concerned, to keep trying to find the right person to go to, because clearly somebody's not looking at the whole picture. Whether or not she has vascular EDS or maybe another type of connective tissue disorder that's associated with vascular issues, or even something else like von Willebrand's is a clotting issue. You know, that's not a connective tissue disorder, it's a blood disorder. And yes, it can be comorbid, but people can just have that. But that can also cause things like she has. You know, I read this other article about, it was on mysterious diagnosis about something like that. It was on a baby, and they had a very rare type of issue with their platelets or something. But it was fascinating because, you know, she had bruising, she had all these things, and it was just this baby. But, you know, a lot of times they were dismissing this baby that was having these weird things. So it's not always a connective tissue disorder or always vascular EDS or anything. But I think that to be concerned about it not being usual is important, and to just keep trying to find the right resources to check that will actually be aware of the bigger picture and to rule it out. Because it's not just about the joints, it is about the vasculature. It can be life-threatening, and it does make a difference in terms of movement, or somebody going and hiking in the woods and being aware of, like, you know, what could or could not happen. I always think about the people that are very outdoorsy, they're very athletic, they're 40 years old, they go skiing and they die. I'm not saying skiing is it, but I give that as an example because I had a really good friend whose husband suddenly passed away at the age of 41, and they never did genetic testing. And I was just like, what? We know this happens, but like, how can you not do genetic testing? It's absolutely baffling. Like, that doesn't just happen. And similarly,
in terms of resources though, is it just preventative, or is there anything, like, is there any therapy that's out there?
It's not just preventative. It's not just I mean, it is preventative, but in terms of like what we're talking about, is not just preventative, but there are therapies that if somebody has a vascular condition, whether or not it's Loeys-Dietz, connective tissue disorder specifically, or even, you know, von Willebrand's and those other things that can cause bleeding like that. I don't know those therapies specifically, but in terms of a connective tissue disorder, there are things that are done. People are put on beta blockers. People are put on these different blood pressure medications to try to keep the pressure of our vasculature down, to reduce the risk of rupture and bleeding internally, or organ rupture, or you know, different horrible things that, you know, stroke and aneurysm and different things. So there are therapies that are important, that are available, and it is preventative. There's no cure, obviously, but there are things that are done. And of course, there's also preventative in terms of just being aware of like when you're outside or how you move. Like for example, like I mentioned, like hanging. You know, if somebody has a vascular connective tissue disorder, I wouldn't necessarily be doing hanging, because not only if they fall, they're at more of a risk, but also just their tissues are just more fragile. Even their skin, you know, they could rip more easily. They just don't have the structure and stability that other people and other hypermobility disorders have, you know, in terms of just, you know, it might be good for them, but it's not great for these people that just have this kind of inherently different type of fragility. So
what do you think about inversion tables? Same thing?
Cool. Same thing, because if you think about it, if they have any kind of internal fragility, you're taking them over and then all of a sudden the blood rushes to their head, and you know, there are a lot of issues in the brain. You know,
right.
You have, you know, the brains are arguably hypermobile. So I think it really is really personally independent. And, you know, I also know that it's also important to note that even if somebody has a more serious, vascular type of connective tissue disorder, they are diagnosed with that, like vascular EDS or Loeys-Dietz or Marfan's, like there's even variances in terms of the phenotypes of people. Yep. And that does seem to be translate in terms of like the severity of their own case.
Okay.
So, and we're never going to know that. We're never going to even be able to solve that, but just understand that not even those that fit into that box still fit into that box. Like there is difference. So it is preventative. And sometimes it's, you know, I know most of us are very holistic and everything, but there are things, you know, people don't really have a whole lot of surgeries, you know, or they try to really prevent them because of the fragility. But there are medications that can help preserve life and serious complications. And, you know.
So like in terms of like the hanging, like you're talking about, if somebody has a vascular issue.
I wasn't trying to badmouth hanging. I was just,
I know what my question is. So like for something like that, is that something that would just always be, no, you probably shouldn't do this, this is not safe, or is that something that's trainable?
In terms of inherent connective tissue disorder that has a mutation, specific mutation that we know is associated with more, you know, tissue fragility and risk, I would say it would always be there. I would never, maybe I would modify it. You know, I don't know that, you know, hanging like this, you know, you know, standing up and like this would be so bad. I'm talking about more like just the inversion or the, you know, hanging from a thing. So maybe I would modify it. It just really depends on the person, you know, and it's hard because people that have more serious issues, they need movement and strength just as much as we do. You know, just as much as anybody else does. But they also have an internal vasculature and connective tissue that when forces and loads are applied, it's not all just biomechanics, you know, in terms of our skeleton and everything. Like the tissues and loads and forces that are caused by blood on the internal organs is just, there's nothing that we can, I mean, that's just inherently part of the tissue. They're just fragile. So we talk about loads and forces in terms of biomechanics, but that also applies arguably internally, and in terms of like the blood flow when we're moving and doing these different loads on our weight-bearing muscles. It also affects the internal vasculature, obviously. And if somebody has a connective tissue disorder that has a mutation that makes the internal vasculature more fragile, it can also, it might be okay to put it here on their elbow or on their body, but internally it just causes pressure on those types of connective tissues that could cause issues. Does that make sense? Probably doesn't.
It does.
I'm trying to see, like, it might be okay biomechanically in terms of what we're looking at, but we're ignoring the fact that the tissues are structured differently elsewhere, and those forces and those might be so good there.
Right.
Okay.
So
the article that you sent me regarding low blood pressure in people with connective tissue disorders or EDS, I think it might have been EDS specifically.
Yeah. Oh, yeah,
so that what is making me wonder is, so the blood pressure was low because the vasculature was lax.
Exactly.
Correct? So it doesn't necessarily mean that it's really like, you know, it's immeasurably low, but that doesn't mean that the forces on the tissues aren't too much for the tissues.
Exactly. So there's another global kind of phenomenon, and again, I'm going to make it broad, is that it is known common in people with EDS, hypermobility related disorders, whatever you want to call it, that they technically it's very common to have low blood pressure. Like my blood pressure is always really low. I also have orthostatic intolerance. You know, I get up and I get really dizzy, and I have Raynaud's where I don't have really great perfusion in joints, and my feet turn purple and everything. But that doesn't necessarily mean I have vascular EDS or Marfan syndrome or more of a serious connective tissue disorder, that the forces biomechanically are pressuring my vascular organs. I'm trying to be in a way that's unsafe. Does that make sense?
Yes.
So what you were saying was correct, and what I said was right. So there is a global just kind of being aware that, you know, we tend to have these things, but that's where movement is really great, and that's where natural movement and restorative exercise, I think, is one of the best things. Doesn't mean that we still not have to be careful, you know. Sure, we all have to be careful, but there's an inherent just kind of global phenomenon that is associated with hypermobility or connective tissue disorders, where the vasculature can be more lax without having a more serious vascular condition. And it does cause blood pooling and different things with, like, you know, just, you know, low blood pressure and, you know, getting dizzy when you stand up, and, you know, your fingers turning blue, and, you know, having Raynaud's or something. So yeah.
Okay.
Yeah, I think that's actually where all of this is really important. You know, I tend to use a lot of restorative exercise principles when I'm outside walking my dogs. I always send pictures of you know, I get so cold and my fingers will turn like freaking blue or white. And, you know, a lot of the principles that we learn is what I apply, you know, daily. So, yeah. Anybody else?
This is awesome. Does anybody have, so we're a little over an hour and a half now. So does anybody have any other questions, any other thoughts that came up? I think we covered, I'm just going back and looking at the other, I think we pretty much covered everything else that was on here.
Yeah, I think, and also, you know, I know that, I know this can be like really overwhelming, and also like, well, how does it really apply to any of us, and is it important? And, you know, I just got to keep doing my classes, and I got to keep studying, and, you know, I think it is important to be aware. I also think that it's really great place to continue. There's a lot of research and discussions that I would love to have, because I think a lot of it is we just really don't know, and I think it's a fascinating area to kind of continue to consider, because I think there's more and more people that we're finding have issues that may or may not be related to something like this, but I think we're gonna have more and more clients that, you know, you're like, oh, wait a minute, they, you know, we see them, and even in our own selves. And I would love, you know, like Carol's question and different discussions, and I wish there was all the research out there to help, but this is where I hope that bridges the gap. There's just a lot that really has yet to be done, and the people that are doing the fascia and movement research, hopefully will talk to the people that are doing the medical and clinical research. It's getting there, but you know, I just think we have a lot to stand to help, and a lot to be done in terms of really helping people appropriately, or being aware of, or answering questions. There's just so much that needs to be really done. I don't know that we'll ever be able to do it, but I think we have a lot of opportunity. So, and if anybody needs resources or just articles or things like that to send to clients, I'm always happy to help. You can message me, and I'm also happy to just kind of put something together that I think is a really, you know, just like a folder, or, you know, presentation, just where you can access just information that might be helpful to kind of understand the bigger picture, but also how to help clients, you know.
Okay. Thank you, Kendra.
Okay, one second. Well, Carla, just unmute yourself and ask your question, because I don't know which one was your question. I didn't see that question. So no, we didn't talk about it. Unmute yourself. Here, I'll unmute you. Okay.
Okay. So I read a while back, or heard it on a podcast, about visceral massage and it being effective for EDS. And I didn't know if you knew anything about this, or had an opinion about it, or knew if there was any research that would support that.
You know, I don't offhand. I could see arguments either way, to be honest. Again, it's, you know, so independent of the person and what they, you know, what type they have.
Well, and now that you've brought up all the vascular issues that I was completely unaware of, it's kind of an interesting.
And not that I mean to say that to make anybody scared, because the reality is that the percentage that you guys will probably have to see or deal with or be aware of is so small. It really is. But it's probably more bigger than we think and we're aware of.
Yeah.
So I mean, I see arguments both ways. I haven't seen anything specifically, but I love massage. I think it's probably one of the biggest things that helps me. But I also see, like, you guys ever heard of like dry needling? Is not massage, but some people do dry needling, or some things just really are like things that are more intense, that it's funny that the tissues don't necessarily respond to very well. I don't know anything specifically about visceral massage, but like I said, I can see arguments either way. So I think it's really independent.
Yes, go.
I was just thinking, in what Kendra's saying about you could see it either way. Like, so it could be too much pressure on vasculature, but if you're somebody who has blood pooling and congestion, why are you laughing at me?
I'm laughing at Carla.
Oh, then I could see how visceral massage would be helping move some of that congestion out of the organ.
I would also say that even if somebody doesn't have a vascular type of condition, if they have a inflammatory disease like rheumatoid arthritis or even fibromyalgia or lupus, like even that type of pressure and it can be a trigger on the tissues and vasculature too, even if they don't have a more serious type of disorder, but it can be equally harmful or triggering, I guess, in some ways to their tissues, and maybe not so great. So it's not just about those that have the more serious things. It could also be, people that they have some other kind of inflammatory process. So it's really, I can see it either way. I mean, I think I posted about when Lisa made the question about the people that don't heal very well. And that's where I shared a little bit more of the mast cell stuff. But I can tell you, I can't stand massage or anything on my legs anymore, like my upper legs. It's like this tissue pain versus muscle. And like my skin hurts. It's like, feels like daggers. It's the weirdest thing because it's not everywhere. And it's unfortunate because I feel like that's the area where I need the most. But there's some kind of a process or something where it hurts in a way that I've never, and I'm just talking massage, but my tissues just respond really weirdly.
I wonder if that would be related to your pelvic congestion.
I would think so. Probably. It's probably all related. I mean, the body's connected. I think you're right. It's related to pelvic congestion syndrome. It could also be related to the fact that I don't have really good perfusion everywhere. My legs are definitely have laxity, and I have a hard time, like, I have to do intense exercise to like get the swelling out of my legs. It's crazy. I've told Carolyn, I've talked about, like, I have this, like, I call it knee fat, but it's like I have this collection of just like skin and fluid that just is on my kneecap. And it's the weirdest thing. And I always look at people's like knees and I'm like, what the heck? Like, nobody has that. I call it knee fat. But it's not fat. It's just this collection of just fluid. And it's just from probably, I guess, it's just, I don't know. It's just extra skin that I have from having EDS or type of EDS. And I was diagnosed with classical EDS, just so you all know. But I have a lot of skin involvement and I have vascular involvement and I have issues with perfusion everywhere, but I don't have vascular EDS. I don't have Marfan syndrome, but yeah, I don't know. I have an issue with like the blood pooling in my legs.
So Kendra, if you could send me some of those resources, because like one of the other things that her and I talked about before we got started today was that, like, you can go to Google and you can get all your WebMD hypermobility EDS info, or you can actually get, more research-based real info, more current, more broad-based. So if you could send me some of that, then I can just put together like a handout that goes along with this conversation. And then if people want to go do more research and read more, and maybe I'll pull out all those links that you put into that other conversation where Lisa asked that question, because you have a lot of information in there too.
I think some of the charts also are really great just to see visually like where certain things are and what is mutated on a cellular level, just to understand that it's not I don't know, just to bring it grassroots, more relatable, and that everybody's not freaking out that they have these patients that might be coming in that have some kind of underlying serious thing. But also understand that there are politics and that there's even differences currently right now in the research and like even the bigger organizations, you know, and what everybody believes and feels. And I guess just take it with a grain of salt. But yeah, I can definitely put together the stuff that's more current and what's accepted and understood currently, although it seems to be changing all the time. And of course, the current terminology, you know, they don't use the, if they're talking about just EDS, we don't use the type 3 or type 1 or type 2 anymore. There's no more of this benign joint hypermobility. Joint hypermobility syndrome is not also a current term. So just being aware of current terms, that's really is helpful. So.
Okay. Well, then I think we should probably, we got.
I hope it was helpful. I didn't mean to overwhelm or confuse or, you know.
Well, I think, I don't know. I'm gonna have to go back and listen again because it's a lot of information. But I think that, I hope you guys, was that like information you didn't know? Like, oh my God, it's such much broader than I ever imagined it was. So thank you so much. And I think that having some extra resources to go and do a little bit more reading will be helpful and appreciated by our colleagues here.
Hopefully there'll be in future, we'll all be able to be part of just doing more research to take what I said and then putting it on a movement and scale, and also what that means in terms of movement and teaching movement.
Yeah, if you could just go out and do all the research to answer all these questions that everybody has that the research does not support as yet, that would be really great. Could you get on that?
Right. I look forward to being able to, you know, collaborate with everybody in the future and hopefully being able to make sense of all this and what that means to us teaching is really critical. So.
Awesome.
All right. Thank you, everybody.
Thanks, everybody. Have a great weekend.
Yeah, thank you.
Bye.